Have the next speaker, Atika Javed Siddiqui. Yeah. Okay, she will be talking about mystery of a unilateral pressurized eye. Please go ahead.
Thank you, ma'am. So my case is, as ma'am said, mystery of a unilateral pressurized eye. My case was a young male, and he came to us with blurring of vision in the left eye for the 2 months, which was associated with mild ocular pain, intolerance to light, redness, and it was more around the bright lights. And this used to occur more often in the morning, and it used to resolve within 4 to 6 hours. And such attacks used to occur every 1 to 2 times per month. And there was no history of any ocular trauma, any curtain effect, any flashes of light. Past history, family history, and personal history was not significant. The general examination and system examination did not contribute to anything. And in the diffuse torchlight examination, everything was normal except for slight congestion in the left eye. In the ocular examination, everything was normal except for the high raised pressure in the left eye. On NCT, it was 50, and on GAT, it was around 48 mm of Hg, and the pupillary reactions were sluggish. On the slit lamp examination, the right eye was normal. In the left eye, we could see a diffuse corneal haze, and we could identify the KPs in the inferior portion of the cornea, and we could also see cells and flare in the anterior chamber. The fundus in the right eye was normal. In the left eye, we could see a CD ratio of 0.6, and although the NRR was healthy. Gonioscopy, the angles were normal. The perimetry was by and large normal. The OCT was normal. So we started him on acetazolamide 500 mg STAD and then TID, and on topical anti-glaucoma drugs, and he responded to this for the meanwhile, and we also started him on an antibiotic and steroids. And we kept him on treatment for around 1 month, and he responded to the treatment, and we generally withdrew the steroid, and he was keeping good on that. But again, after almost 4 months of treatment, he again presented to us with high pressures and the KPs and all. So again, we put him on acetazolamide, and we followed closely. This time we did not give him a steroid because we were suspecting that he could be a steroid responder. So we put him on Nepafenag. But he did not respond, and on almost 2 weeks, 1 week after the treatment, he was still having a pressure of 42. So this is the GAT values over time which the patient had. And we came to a provisional diagnosis of a Posner-Schlossman syndrome because it was a unilateral presentation. He had recurrent attacks of IOP with anterior uveitis. The angles were open, and there were no visual field defects. And these were the differentials we had in mind. So we planned for a left eye trabeculectomy with mitomycin C and mannitol as the pressures were high, and we monitored the vital. And this was a picture of a post-op day 1. The patient responded, and the pressure came down to 25. And on post-op day 10, the pressure came out to around 10, and the patient is doing well. We still have the patient on follow-up, and we are looking for the other eye, if the other eye is okay or not. So Posner-Schlossman syndrome involves episodic unilateral spikes in intraocular pressure with minimal inflammation and mild visual discomfort. It has associations with autonomic dysregulation and viral infections, particularly cytomegalovirus, and it may often go unnoticed. Symptoms include blurred vision and mild discomfort, which our patient had, and without significant redness or pain, but our patient had pain. The differential diagnosis may include acute angle closure glaucoma, herpetic keratouveitis, and Fuchs' iridocyclitis. So IOP is usually managed with beta blockers, alpha agonists, and carbonic anhydrase inhibitors like we did, and corticosteroids, they help control inflammation. So surgical interventions like in our patient we did a trabeculectomy. It may be necessary to prevent recurrent attacks. Since our patient was young, we did a trabeculectomy to prevent further damage to the disc and further progression of glaucoma. So although PSS is often self-limiting, repeated episodes may lead to glaucoma, and long-term monitoring is crucial to prevent progression to open-angle glaucoma. So the take-home message is that the rise in the Posner-Schlossman syndrome, the rise of IOP is out of proportion to the severity of the uveitis, and this rise in IOP precedes the identified inflammatory reaction. A high index of suspicion is therefore necessary. Thank you.
So, interesting case, Posner-Schlossman is available.
Yes.
Yes. Right. Okay. Yeah. So did you do a PCR for CMP before doing a trial?
No.
Okay. And another thing which I find, I'll just go with my chairs also, what do they see? I find very often in uveitis we use an antibiotic steroid combination. There is virtually no rationale for using antibiotics, and we've seen just now the body and the weight with the moxie and everything. We should stop using a combination therapy for uveitis. There is no proven rule of putting moxie or gatti or Oflox. So in future, just give plain steroids for this thing.
Right, ma'am.
And why did you think it was a steroid responder? Because he had multiple episodes as per the history, and that time he wasn't on any inhaled or oral or any steroids.
He's a young patient, he was not giving any history. But in a country like ours, it could be like the patient is hiding something or he's not giving a proper history. So the next time when he came, we did not purposely give a steroid. So that we have to rule out all the causes before taking up for the surgery.
But moment you have KPs and you have, do you have flare in this patient or just KPs?
Mild flare, but cells
So
were
mild flare and KPs causing a uveitis, there is no option but to give steroids. You know, it's a double-edged
Yes,
sword,
yes.
but you have to do that because you have to prevent glaucomatous damage. So my take would be, definitely it's a very worked up case, and it's always a diagnosis of exclusion post-Schlossman. But if you have the option, do a PCR. All the time option is not there, but definitely do not use an antibiotic steroid combination.
Ma'am, I have a question, I'm sorry.
please.
So if, because I can take the opportunity to ask to you, but if you do a PCR and we find it is a positive for CMV, so what would be the take ahead message and what? how
Then
would
you start treating for the CMV or the virus which you find, because the recurrence can happen, and usually it is unilateral, but it may go into the other.
Because
eye.
we have
it's
the
for
patient-
prognostication of
Yes, ma'am,
the.
because we have the patient for follow-up, so maybe we
But
can
now
go
to
back
do an
and-
aqueous tap, intervention procedure, now you have to justify that.
So, ma'am, can we go for the other eye also?
No. Why? If there's no, see,
So we have-
anything which you have to intervene, aqueous tap has to be done. If there's no symptoms, you would not. But if you were doing a trap, at that time you could have taken the aqueous tap and studied that. So that's just a learning. All the patients come to us with learning.
Yeah.
So next time when you do, arrange for that.
Any role of oral antivirals in the initial part of management?
Two comments related to the case. So one is in the clinical picture you showed, the affected eye had a cupping of about 0.6 and the
Yeah.
other eye was normal, and KPs also were there in this eye. So very likely the patient has had previous episodes, may not have been symptomatic though.
And he was having a
Yeah.
history of around 1 to 2 months. He has showed elsewhere. He had
Yes,
no documents. And we were suspecting, and he was going into progression.
Yes, so no, not just that. All I'm saying is that given the 0.6 cupping, because Posner-Schwarzman is typically a recurrent kind of a picture.
Yeah.
So most likely he has had previous episodes, but they were probably not symptomatic, so he has not sought treatment. That is the first comment. The second comment is that in Posner-Schwarzman, when you look at your case carefully, you stop the steroids completely, and the patient came back with a recurrence and a high IOP.
Yeah.
Right, so I think at that point of time it would have been wiser to start the steroids and not the thinking that he's probably steroid responder.
And at that time,
Yeah.
we did not look for till the time he was having inflammation in the AC, we started him on steroids. But the time the inflammation subsided, we tapered the steroid.
Absolutely. So at that time there was no high
Yeah,
IOP.
yeah.
So that goes against the diagnosis of a steroid responder.
Yeah.
And when he came back, you should, instead of giving a Nepafenac, maybe if you had given steroids, that would have controlled the episode and would have avoided the trabeculectomy altogether. That is the first, but again it's speculation because we don't know what happened to your case. Okay, the second comment relates to the antiviral which you were asking. So of all the studies that have been done in Posner-Schwarzman and what has been found, what I have read earlier is that topical ganciclovir can help in preventing the recurrences in patients who have recurrent episodes. But again, recurrent episodes would be at least at least you have some 3-4 episodes. So topical ganciclovir may help. So you could look that up further. There is a very nice review on this. Yeah.
Thank you.
So I would also like to make a comment. So it was an excellent discussion and a different case, unique case. But what I saw was your post-op picture. It showed some Sineca in the immediate post-op picture, and the medications that you put the patient was cycloplegic HS.
Yeah.
So post-trap, we generally give, cycloplegic cycles to prevent posterior Sineca formation. That is very important because once you form the posterior Sineca in the immediate post-op period, they tend to remain for life. So the pupil should
But
be
it was
kept
on day one
mobile.
and he responded well to tropicamide.
Your
You
pictures
give
showed,
cycloplegia,
yeah.
you don't give tropicamide. For TRAPS, either you give atropine or you give homatropine or cyclopentadate, whatever the protocol is. But tropicamide definitely is not adequate enough. In fact, we give TDS for the first 1 week and then we triple down to
Cycloplegic,
H.
ma'am.
Yeah, always cycloplegic. In children, atropine because they have a more, and uveitic, you're leading with a uveitic glaucoma now.
Yeah.
So you have to give cycloplegic. Thank you. I think we have to, otherwise we'll not be, that's a very interesting discussion.